Hello, my name is Sarah Fuchs. I am a clinical pharmacist at the Harry S. Truman VA Medical Center. I currently practice on our community living center floor, which we see patients who are in long-term care, short-skilled rehab, and patients who are on hospice. Now, today we are going to be discussing the most recent updates to the American Geriatrics Society Beers criteria. So let's go ahead and get started. All right, so first, just so you know, I have nothing to disclose with this presentation. The learning objectives for today include identifying changes to the most recent update with the Beers criteria. So we're going to look at removals, changes, and any additions. And then we're going to apply those changes to a patient case. So just a little bit of history. The Beers criteria was originally released in 1991 by Dr. Mark Beers. It's thus been released by the American Geriatrics Society. It was last updated in 2015. And this was kind of a big update. It included significant drug-drug interactions. It included renal dosing tables for specific meds, and there was information printed about safer alternatives to these potentially inappropriate medications. So the most recent update was released in January of this year. All right, so just a little disclaimer. Any deletions or removals from this list is not an endorsement of use of that medication or class of medication. And we'll go over the specific reasons for those removals or deletions. So I just wanted to review the tables with you that we'll be going over that are included in the Beers criteria. So table 2 looks at potentially inappropriate medications, specific reasonings for why they should be avoided, or what the criteria is. Table 3 looks at specific drug syndrome or drug disease state interactions. Table 4 looks at medications that should be used with caution in elderly patients. Table 5 looks at specific drug-drug interactions that should be avoided. Table 6 looks at medications that should be adjusted or avoided depending on kidney function levels. And then Table 7 lists drugs that have strong anticholinergic properties. And I just wanted to talk a little bit about why we're so concerned about anticholinergic properties in elderly patients. So a lot of what we try and do as patients get older is reduce fall risk. Falls can be extremely detrimental to an elderly patient. They don't generally bounce back quite like a younger patient can. We have seen that falls can increase morbidity, mortality. So we really try and do several things to reduce fall risk. Just as a reminder of what anticholinergic effects include, this can be effects such as like flushing, confusion, potentially psychosis in some cases, constipation, urinary retention. So all of these types of things can be very harmful to a patient and increase their fall risk or worsen other disease states that they may have. All right, so let's jump into some of these changes. Okay, so in Table 2, so remember this is our potentially inappropriate medication use. Removals from this table included the antithrombotic agent ticlopidine and opioid analgesic pentazocine. And the reason for those removals were these agents are rarely used anymore. And actually, these two agents specifically are not on the market in the US anymore. So you cannot use them. Changes to this table included for digoxin for the indication of AFib and heart failure. The recommendation is really not to use digoxin as a first-line agent for these indications. What was changed in the criteria was the rationale for that reason was modified and specified more why it shouldn't be used first line, and the quality of evidence for the indication of atrial fibrillation was changed from moderate to low. Sliding scale insulin is on this list, and they clarified the recommendation with this most recent update. It states now that to avoid insulin regimens that include only short or rapid-acting insulin dosed according to current blood sugar levels, so like kind of more of like a reactionary approach, without the use of basal insulin. So the recommendation doesn't apply to regimens that already have basal insulin in place. So if the patient's already getting Lantus or Detamir, and they have more of like a sliding scale or corrective scale short-acting insulin, that is okay. And the sliding scale insulin avoidance recommendation wasn't super clear. It was past versions. For metoclopramide, they added a duration of use of more than 12 weeks for treatment of gastroparesis to be avoided. And then peripheral alpha-1 blockers, so these are like terazosin, prazosin, doxazosin. They clarified that they really should not be used for hypertension. These are still okay to be used for BPH, but really should not be used first line for hypertension in elderly patients. Additions to Table 2 included glimepiride. The reason for this being that glimepiride can potentially cause severe prolonged hypoglycemia in elderly patients. Glyburide was already included in the criteria, so it was added to that. And then methylscopolamine and pyrilamine were both added as these agents have strong anticholinergic properties. Okay, so moving on to Table 3. This looks at inappropriate meds for specific drug disease or drug syndrome interactions. So removals from this table included the drugs that could potentiate chronic seizures and epilepsy, and patients who already have those. Those drugs that were listed were bupropion, antipsychotics, and tramadol. The reason that this was removed is that risk for potentiating seizures is really not unique to older adults. Basically, anybody who's on those agents that have a history of seizures or epilepsy are at risk. Insomnia, the drugs that can potentiate worsening insomnia include oral decongestants, stimulants, theophylline, caffeine. And again, the reasoning that this was removed is that risk is not unique to older patients. With Parkinson's disease, aripiprazole was removed as the preferred antipsychotic agent due to safety and efficacy concerns with use of aripiprazole. Okay, moving on to changes within this table. We really looked at histamine 2 receptor antagonists under medications to avoid in delirium and dementia. Basically, they changed the level of evidence for those agents from moderate to low in the setting of delirium and removed the class as one to be avoided in patients who already have dementia or cognitive impairment. And this kind of came about. There was a study that was published in 2017 that looked at proton pump inhibitor use and the risk for developing mild cognitive impairment. It was a large observational multi-center longitudinal study over 10 years from 2005 to 2015. And basically every proton pump inhibitor agent that's on the market was looked at. And the study actually did control for H2RA use. And what they concluded from this study was that proton pump inhibitors were not associated with a greater risk of developing dementia. And by controlling for H2RA use, they were able to observe that the risk for developing dementia was low with these agents as well. So they're maybe not as large of a risk in this setting for potentiating worsening confusion. I will say, though, there are still risks for use in elderly with these agents. For proton pump inhibitors, there's increased risk for bone fractures with falls, increased risk for developing nosocomial pneumonia. And just as a reminder, HRAs are renally dosed, so that should always be taken into consideration. Under medications to avoid in patients with history of falls or fractures, the strength of recommendation for opioids is listed as strong. As we all know, opioids can increase that risk of falls, so we try to limit use as much as we can in appropriate settings. Non-steroidal anti-inflammatory drugs, COX-2 inhibitors, and TZDs all can potentially increase heart failure symptoms, so they really should be used in caution in patients who have heart failure. Okay, additions to this table include your SNRIs, such as duloxetine, venlafaxine, desvenlafaxine, two existing SSRIs and tricyclics in patients who have a history of falls and fractures. And then again, back to kind of the Parkinson's disease, pimavanserin or Nuplazid was actually recognized as an acceptable treatment for psychosis associated with Parkinson's disease. This is kind of a newer agent that's come out, and its indication is for psychosis with Parkinson's. And the mechanism of action is primarily acts on serotonin receptors and does not have an affinity for dopamine receptors, which is what makes it ideal in this setting. So the criteria in this update indicates that really all antipsychotics should be avoided in Parkinson's disease, with the exception of pimavanserin, clozapine, and quetiapine. Okay, so moving on to table 4, medications to be used with caution. So removals from this table include carboplatin, cisplatin, cyclophosphamide, and vincristine, with there's being a risk for SIADH and hyponatremia. The reason that these were removed is that these medications are highly specialized, and it was felt that they kind of fall out of the scope of the Beers criteria. Basically, the specialty provider should be assessing risk versus benefit when using these agents. And then vasodilators, there's a risk for syncope with those agents. And again, like we've seen before, this was removed because that risk is really not unique to the elderly population. So they're still at risk, it's still not recommended, but everyone's at risk for that. Okay, changes within this table. The age cutoff for using aspirin for primary prevention was decreased from greater than 80 years old to 70 years old. There have actually been quite a few studies published this past year that look at risk versus benefit of aspirin for primary prevention. Just to point out a few, so the ASPRI trial came out that basically showed that daily use of aspirin did not provide any additional benefit of disability-free survival in elderly. And then the second trial listed really showed that there was a significantly higher risk of bleeding in patients who are taking a once-a-day aspirin compared to a placebo. So for patients who don't have a significant cardiac history, who are older than 70 years of age, they may not need that once-a-day baby aspirin for cardiac protection. Okay, additions to this table include rivaroxaban for the treatment of venous thromboembolism or AFib in patients who are older than 75. Dabigatran had already been included in the criteria, so this was added. There's an increased risk of bleeding. And just a reminder to really watch in patients who are also on amiodarone, fluconazole, rifampin, or phenytoin, as those are significant drug interactions that can further increase that risk of bleeding. Dextromethorphan with quinidine or Nuedexta, its indication is for pseudobulbar effect. It's a highly anticholinergic agent. There's a potential for increased fall risk and other drug-drug interactions. sulfamethoxazole with trimethoprim in combination with an ACE inhibitor or ARB in patients who already have decreased renal function should be avoided or limited, as there's risks for toxicities, development of high potassium levels, and acute kidney injury. And then tramadol was added as there's risk for development of SIADH and hyponatremia. Just a reminder that tramadol does act on serotonin receptors, so that there is that risk. It is important really to check labs on these patients who are using them routinely for pain. Okay, changes to table 5. So remember, that's the drug-drug interactions table. Basically, for the ACE inhibitor drug interaction recommendation was broadened. In the 2015 criteria, it just listed to avoid use with triamterene or amiloride. And in the 2019 criteria, it said to avoid a combination of more than one of the following. So ACE inhibitors, ARBs, aliskiren, spironolactone, or eplerenone, as this can increase the risk for development of hyperkalemia and acute kidney injury. You really should avoid a combination of one or more of these agents in patients who already have poor renal function with CKD stage 3 or worse. Further changes, so the combination of opioids and benzodiazepines was already in the criteria, but they've also added the recommendation to avoid the combination of opioids and gabapentinoids, so gabapentin and pregabalin, as there's increased risk for severe sedation-related adverse effects, respiratory depression, opioid overdose, can potentially lead to death. So it's a very significant interaction that really should try and be avoided. There was a case control study that looked at this that showed there was that increased risk. There is an exception to this recommendation, and that is for patients who are transitioning from opioid treatment to gabapentin or pregabalin, so if they're doing a cross taper with eventually getting to monotherapy, or if there is like a short course of gabapentin being used to try and reduce opioid dose. But really, caution should always be taken if you have patients on both opioids and gabapentinoids. And just as a reminder, gabapentin is renally dosed, so make sure you're always looking at their overall daily dose and the frequency of dosing in patients who have poor renal function. Okay, and then this one was added that basically to any combination of more than 3 central nervous system acting drugs should be avoided. As you can see, there are several agents that have effects on the system, but just being on more of those agents increases the risk of falls, increases the risk of fractures. So the overall goal is really to minimize the number of CNS acting medications as best you can. Okay, additions to the drug interaction table include phenytoin with Bactrim, as this can potentially lead to phenytoin toxicity, theophylline with ciprofloxacin, as this can lead to theophylline toxicity, and then warfarin with several different antibiotics, as this combination can increase bleeding risk. It's increased that INR pretty significantly. So trying to avoid use of any ciprofloxacin, macrolides, or Bactrim with warfarin, if possible, is ideal. If there really is no alternative antibiotic, it's really important that the INR is monitored closely, the patient's monitored for signs and symptoms of bleeding, and that the duration of antibiotic is limited as best as possible. I know that for my patients on warfarin that have to be on Bactrim, I go ahead and empirically reduce that dose just because it can increase INR pretty significantly. Okay, so moving on to the renal dosing table, there weren't any removals from this table. There were a few changes. All of the newer anticoagulation agents, so the NOACs, apixaban, dabigatran, edoxaban, and rivaroxaban, they had already been included in this table, but the creatinine clearance levels, the cutoffs at which doses should be adjusted or the medication should be avoided were specified with this newer update. And those updates were just based on the current labelings of each product. Additions to this table included ciprofloxacin, so reducing the dose if their clearance is less than 30 due to risk for CNS effects and tendon rupture. With Bactrim, reducing the dose if their clearance is between 15 and 29 and avoiding use if their clearance is less than 15. Like we've said, it can potentially cause hyperkalemia and acute kidney injury. And then dofetilide, reducing the dose if their clearance is between 20 and 59, avoiding use if their clearance is less than 20, and that's due to risk for QT prolongation. Okay, so I know that was a lot of information, and please feel free to ask any questions if you want anything specified, but right now we're going to do a patient case real quick. So we've got our 78-year-old male whose daughter brings him in for a follow-up with his recent skin infection. He was started on antibiotics 5 days ago, and today we get some labs and we show that he has got a potassium level of 5.6, so it's a little bit high, and his renal function has decreased, and you calculated his creatinine clearance and it's at 20. So listed are his active medications. So which medication is likely contributing to this patient's hyperkalemia? Is it the oxybutynin, the glipizide, the Bactrim, or the diphenhydramine? I'll give you guys just a couple moments to think that over. All right, so the correct answer for this is C, the sulfamethoxazole with trimethoprim. The patient has poor kidney function, and he's also on lisinopril, so that can increase his risk for developing hyperkalemia. All right, and so there are my references, and then what questions do you guys have for me? There's a little chat box at the bottom. I've also included my contact information if you think of any questions or would rather email me with your questions. All right. Okay, so I've got one question that says, when empirically decreasing warfarin with 5 days of Bactrim DS, how many days do you reduce the warfarin? So usually with my patients, I reduce their warfarin that first day it's started, because that's usually when I'm finding out the Bactrim is being started. And I tend to get a level, an INR. I tend to get an INR level about the next day or a few days after, just to make sure that INR is not going up super fast. And then just continuing to check it as best I can. I am in a setting where I can get labs every day. I know in the outpatient world that may not be able. So hopefully that answered your question. I also did want to mention you guys will be receiving an email in just a little bit with a link where you can finish up the questions and get the CE you guys needed. So be looking out for that email. I really appreciate all of you paying attention, and thank you guys. Have a great rest of your day.